So we are going to discuss the stroke localization. It is very important during the your ward cases will be there. So we'll come across such cases and you have to take the history. So actually in this stroke localization, if you see the detailed, if you take the detailed history and accurately if you taken, so the history alone is sufficient to reach the correct diagnosis. And in the majority of the neurological cases, the history itself is enough, and we do the bedside examination, okay, and that primarily will confirm you, okay, or it will refute the hypothesis that you have made by taking the history. So the history taking is the only important thing here. Later we do the some clinical examination bedside, okay. So we'll discuss the hemiplegia and stroke localization, okay. So let's see some definitions and the core terminology. So the WHO says that the definition of stroke is a rapidly developing clinical signs of focal disturbance of cerebral function with symptoms lasting 24 hours or longer or leading to death with no apparent cause other than non of vascular origin. So we have to focus here that it is rapidly, okay, so it is developing rapidly and there is a sign of focal or global disturbance of the cerebral function, okay. This is our cerebrum. So the cerebrum, what all things it controls, okay, mostly the corticospinal tract that is originating from here and all, it is controlling the motor functions, okay. So there will be a disturbance in it and it will be lasting for 24 hours or it may last more than that also, okay. And the main thing to notice is that the reason, okay, the reason behind it is the vascular. So it is always the vascular origin, no other causes, right? So as in the beginning I said that when we take the detailed history, it itself is alone sufficient to reach the correct diagnosis in great majority of the cases, okay. The bedside examination that we are doing primarily, either it will confirm the hypothesis that we have made during our history taking, okay, it will either confirm it or it will refute it, okay, rather than being the primary diagnostic step, okay. So you will be coming across some different terminologies while studying the different books like Harrison's, Davidson and all. So I have just compiled it at a place. So the first is TIA, it is transient ischemic attack. So earlier, like TIA was mainly defined by the time the neurological deficit should disappear within 24 hours, okay. But today we don't define TIA like simply by the duration of the symptoms, okay. How we define it, the patient like develops a transient neurological deficit because of some focal brain, spinal cord or retinal ischemia, okay. But there is no evidence of any acute infarction or brain imaging. So while doing the brain imaging that we do here, that is DWI MRI. DWI is basically we do, it's basically diffusion weighted imaging, okay. So actually it tracks down how the water molecule moves inside the cell, inside our body tissue. So when we do that, okay, so we find no any evidence of acute infarction, okay. So there is no signs of any acute infarction, okay. For example, suppose a patient suddenly develops weakness, okay, of the right hand, and there is a difficulty in speaking, he can't speak nicely. After 30 minutes, okay, everything becomes normal, the weakness is gone, the difficulty in speaking is gone, okay. So if there is no if there is a no any acute infarction while doing the appropriately the imaging and all, so if there is no any acute infarction on the appropriate imaging, so we call it a TIA, means there should be no any signs of infarction on doing the MRI, DWI MRI, diffusion, that is a diffusion weighted imaging, okay. Now coming to the next part, that is RIND, okay, or reversible ischemic neurological deficit. So this is actually an older term. So this was used when neurological deficit will be lasting more than 24 hours. Okay, but eventually there should be a complete recovery, and there should be a complete recovery before the 7 days. So the duration here they just put between the 1 day to 7 day, you can think like that. So for example, a patient coming with hemiplegia and the weakness is persisting for 2 or 3 days, and the patient completely recovers after that. So earlier this could have been told under the definition of RINT, but today we are not using these terminologies, these are obsolete now. And if you ask why it is obsolete, because the modern stroke classification depends much more whether the brain infarction is present or not. Okay, rather than simply counting the number of hours, how many hours happened, we don't see that. We see whether there is a brain infarction present or not. Now coming to the other definitions like stroke in evolution or progressing stroke, what is the mean? So stroke in evolution is already known as progressing stroke. So idea is very simple. The neurological deficit is getting worse after the patient presented to the hospital, and for example, a patient is coming with a mild weakness in the right arm. Okay, and after few hours the weakness becomes severe. So the neurological deficit is progressively increasing in this case. That is what was traditionally described as stroke in evolution. But remember, this term is becoming less preferred in modern stroke terminology because it doesn't precisely tell us the underlying mechanism. Okay, so is the neurological deficit worsening? And if it is worsening, so we need to urgently look for causes such as any ongoing arterial occlusion or any like cerebral edema, okay, or any hemorrhagic transformation or any seizure activity or any some metabolic problems. Now coming to the completed stroke definition, the neurological deficit has reached its maximum severity and has become stable, okay, without further progression. Remember this, there is no further progression. The weakness is being constant, the same. There is no increase or decrease. Okay. Suppose a patient is developing left side weakness, okay, and the weakness reaches its maximum severity, then remains stable for the next several days. So traditionally it would be called as a completed stroke. So just remember the progressing deficit, that is stroke in evolution, and if there is a maximum and a stable deficit at the beginning itself, it is completed stroke. Now on moving ahead, we have come across the stuttering hemiplegia. So here the neurological deficit does not simply like progressively it is worsening continuously. It is not like that. Instead it fluctuates. There is a fluctuation. Okay. So suppose a person has developed right side weakness. After some time the weakness has been improved, no problem. Then again the weakness comes back in the right side weakness, again it comes back, then it again improves again, then it is normal. So it is there, it comes, it improves, it comes, it improves. But to keep the thing in mind is, it is the same vascular territory. Understood? So a neurological deficit is coming and going in the same vascular territory. So this pattern is called stuttering hemiplegia. So definitely it can be particularly concerning because it may indicate an unstable vascular situation such as like severe carotid stenosis or internal or intracranial arterial stenosis, okay, or intermittent occlusion. This can be the indicative because the vascular territory is same over here. And so whenever you hear like there is a weakness comes, improves, comes back, and this is happening repeatedly, think of stuttering neurological deficit. So to summarize the TIA was no infarction was present, okay, there was no infection when we did the MRI. Okay. Then coming to the RIND, it's an older term, but here the deficit was lasting more than 24 hours, and then there was a followed by complete recovery. Okay. Now this terminology is not used. Okay. Stroke in evolution was nothing but there was a neurological deficit keeps on worsening. Okay. Now there was a completed stroke, and that the deficit will reach maximum, okay, at onset itself, plus it will stay stable. Okay. Now in the stuttering hemiplegia, I said you the deficit will come and goes. Okay, again come and goes, but the important is same vascular territory. Okay, so these are some definitions that we discussed. Okay, this is not using nowadays. So coming to the first one, it was transient ischemic attack. Second was reversible ischemic neurological deficit, it is RIND, stroke in evolution, completed stroke, and stuttering hemiplegia.